are we doing next? Question 4.
What's your email?
It's very pretty. It's very big. It's very big green building on the lap of the north. It's so like yeah, that's what that is. I'm Marshall, by the way. Nice to meet you. Are you from Maine?
I did one case application.
It's not working. Yeah.
So hello, everybody. My name is Julianne Bingeler-Casey from Mayo Clinic in Rochester, and I would like to start the session number 4. We have fabulous speakers to present excellent data, and if we could get started with that, it'd be fabulous on time. Our first speaker is Valerie Armstrong, presenting a 22-year experience with bariatric revision surgery. What have we learned? From the Mayo Clinic in Arizona, the member closer will be Dr. James Medura, and Dr. Carl Libert from Stanford will discuss. Thank you.
All right, thank you all for the opportunity to present today. I'll be discussing our research on bariatric revision surgeries. Sorry, how do I go to next? Is it thanks. We have nothing to disclose. We see a troubling trend in the rise and severity of obesity in the United States. I'm going to go through a couple heat maps to kind of highlight how dramatic this change is. Just 35 years ago, we can see just a handful of states with an obesity rate in the single-digit percentages. Over the course of 35 years, we can see this dramatic increase in the United States, to the point in 2020 where we can't find a single state with an obesity rate less than 20%. Again, this difference is very dramatic. While only 1% of the eligible population undergo bariatric surgery, we are seeing a rise in the number of procedures being performed. Along with this rise, we are seeing a rise in the percentage of revision procedures being performed, and this really started to increase in the year of 2014. Here, I'd like to show the breakdown of the procedures being performed over time. You can see by far and away the most common procedure performed is the sleeve gastrectomy. And here, this red line highlights the revision procedures being performed per year, and this increase mirrors the trend of the sleeves being performed. The purpose of this study was to analyze the trends and indications for revisions in bariatric surgeries. Our study was a single institution, multi-site database created of patients who underwent bariatric revision surgeries over a 22-year span. We excluded patients who underwent revisions outside of Mayo Clinic Enterprise and those who were less than 18 years of age at the time of revision. We evaluated patient demographics, procedure trends, revision indications, and outcomes. A total of 846 patients were included in our study. Of those, 276 underwent gastric banding as their primary procedure, 413 gastric bypass, and 157 underwent sleeve gastrectomy as their primary procedure. Here you can see the trends in the primary procedure throughout our study. The bypass procedure revisions remained relatively steady throughout our study with an average of 21 revisions per year performed. The sleeve revisions, you can see here a dramatic increase in the number of revisions being performed, with only 4% of revisions in the earlier years of our study being done on sleeves. And in later years, you can see it's well above 50%. Weight regain and inadequate weight loss was the most common reason for revision overall at 51%, with a significant upward trend throughout the duration of the study at 6% in the earlier years and 74% in the later years. Reflux was the second most common indication for revision overall at 21%. Here you can see the downward trend line is our other category, which included things such as ulcers, fistulas, dumping syndrome, bowel obstructions, bleeding, etc. Sleeve gastrectomy and banding were most likely to undergo revision to bypass at 76% and 67% respectively. Most revision procedures performed were revisions to bypass. We are also starting to see more endoscopic interventions as revisions to gastric bypasses. Regardless of revision procedure, you can see that our postoperative ED visits and morbidity and mortality rates were the same. Mean BMI at the time of revision procedure was highest among those who originally underwent gastric banding at 41.2, followed by our bypass group at 36.6 and sleeve at 35.7. Among those who underwent revision for weight regain, we saw an average BMI change from revision to most recent follow-up of 3.3 kilograms per meter squared. And here you can see that conversion to Roux-en-Y bypass consistently yielded better weight loss results. Among patients who underwent revision procedure for reflux, you can see here that there were significant improvements in symptoms across all categories of revision procedures. Patients who initially had gastric banding experienced the highest percentage overall of resolution of their symptoms at 83%. Regardless of the primary surgery, patients who underwent revision to bypass for their symptoms experienced a higher percentage of symptom resolution compared to patients who underwent sleeve gastrectomy as their revision procedure at 69% versus 33%. Our study is not without limitations. The retrospective design and single institutional database really limits the generalizability of these results. Additionally, we had a short median follow-up of only 31. And while this was a pretty robust database, on subgroup analysis, some of our groups were pretty small. Despite these limitations, there are several important conclusions we can draw from this study. Bariatric revisions have varied over time related to the incidence and success or failure of the most popular primary operations being performed. Sleeve gastrectomy has become the most common operation to undergo revision. Weight regain or inadequate weight loss were the most common reasons for revision in our series. A majority of revision procedures performed were conversion to bypass, which yielded the best results and most recent follow-up in the categories of weight loss and symptoms of GERD resolution. Thank you for the privilege of the podium.
All right, thank you, Dr. Bigener-Casey, and thank you to the Western Surgical and Program Committee for the opportunity to serve as a discussant for this paper. And congratulations to Dr. Armstrong and her co-authors for this excellent work, and thank you for providing the manuscript for review well in advance. This multi-site retrospective study of patients undergoing revisional bariatric surgery over more than 20 years outlines the indications, the outcomes, and revisional procedure trends, and provides important insights into the evolution of metabolic and bariatric surgery, its procedures, guidelines, and approaches for revisional surgery over time. The authors describe nicely how the trends of revisional bariatric surgery have shifted as gastric banding has fallen out of practice and sleeve gastrectomy has become the most common bariatric surgery procedure performed. I have 3 questions for the authors. First, were these patients' original bariatric surgery operations performed at the same institution? And if so, do the authors have access to the total denominator of these procedures in order to calculate overall rates of revision associated with each procedure over the 22-year period? My second question is for the patients who underwent revisional surgery due to inadequate weight loss or weight regain, can the authors comment on how many of these patients underwent treatment with weight loss medications prior to revisional surgery? And what, if any, effect did that have on the average change in BMI seen after revisional surgery? And my final question, with the increased use of GLP-1 receptor agonists such as semaglutide, also known as Ozempic and Wegovy, can the authors comment on how weight loss medications may impact future trends in revisional bariatric surgery, specifically how you envision the treatment paradigms may shift for patients presenting with inadequate weight loss or weight regain after bariatric surgery? Thank you.
Thank you, Dr. Liebert. Very insightful comments. Thank you for the opportunity for us to present this work here again. Most of our patients are did not have their primary operation performed in a Mayo Clinic facility. They're usually referred in from outside. That being said, we do have patients, and what I think you've seen in some of those trends are some of our gastric bypass patients that we didn't usually have much in the way of revision operations for weight regain. We are now doing some endoscopic treatment with an anastomotic reduction and pouch reduction in the endoscopic suite. So that is an added potential for gastric bypass revisions that is reflected in the data. I think your question about what is the denominator is what I wanted to find out too, and I had hoped we could pull that from the MBSA QIP participant user files. That's where those big numbers came from, that we have that revision rate that has increased over time, but that just doesn't have enough data on what the primary operation was that resulted in a revision. We thought this was a way to get to some of that information to see what was being revised and what it was being revised to and what the outcomes were because of that. We don't have information on use of the new GLP-1 agonists prior to surgery or after revision surgery or after primary operations for weight regain. We're collecting that data. That the use of these medications really just took off in 2021 when Wegovy got the primary FDA indication for weight loss. Up until then, it was diabetes and weight loss. So we're really just seeing this robust use of these medications, and they're changing the game for sure. I don't think it's going to eliminate bariatric surgery. It may delay it. We have seen one of our insurance providers has a new policy that they will cover bariatric surgery for the new guidelines of 35 and 30. With and without medical complications, as opposed to 40 and 35. But the patients have to be on one of these medications for 3 months prior to them approving surgery and still be in those weight range categories. So that's going to change the game a little bit for us. As Dr. Armstrong pointed out, only 1% of people who meet indications for surgery actually undergo surgery. So I think there's still going to be a large population that's not really going to change our numbers all that much. With regards to the effect of these medications on surgical outcomes with or without a revision, what we see in 2 other populations, patients that have a revision do not lose as much weight as patients who have a primary bariatric operation. And whether that's a metabolic thing or the habits that led to their needing a revision in the first place, we don't really know. But I'm thinking that if they lose weight before surgery, they probably won't have quite as robust a weight loss after a revision surgery. And then finally, I think we touched on a little bit what the GLP-1s are going to do to our algorithm. They are definitely going to play a role. There's still a lot of questions out there: expense, availability, long-term payment. I've also seen a policy from an insurance program that says they're only going to have a $20,000 lifetime maximum that they'll pay for weight loss drugs. So that's going to affect our algorithms in some yet unknown way. Excuse me.
Thank you so much. Any questions from the floor?
Great, thank you.
Our next presenter is Dr. Neil Bhutani, discussing does extramural vascular invasion predict response to neoadjuvant therapy in locally advanced rectal cancer. The member closer will be Dr. Abhinat Uppal, and Sherry Wren will be the discussant from Stanford University.
Thank you. Thank you very much to the Western Surgical Association for the privilege of the podium and the opportunity to present our work here today. Here are our disclosures. So of all the patients who are diagnosed with rectal cancer in the United States, an increasing proportion is presenting with locally advanced disease, defined as T3 to 4 primary tumor category or M-positive disease. And these patients are at increased risk for local and distant disease recurrence. 5-year survival varies widely for this population. Among patients with rectal cancer, extramural vascular invasion is defined as a direct invasion of a blood vessel, usually a vein, outside of the muscularis propria of the rectum by tumor cells. And EMVI is a marker for aggressive disease. These patients often present with higher rates of recurrence and lower rates of survival. The use of EMVI as a marker for response to neoadjuvant therapy in the era of TNT, however, remains incompletely defined. Prior work has shown that EMVI is a marker for decreased response to chemoradiation, but again, this hasn't been explored in the TNT era. So the objective of this study was to delineate the predictive value of EMVI with respect to outcomes after neoadjuvant therapy. Our study cohort comprised patients treated with locally advanced rectal cancer with EMVI on initial staging pelvic MRI at the University of Texas MD Anderson Cancer Center. All the patients included received some form of neoadjuvant therapy, whether preoperative chemoradiation or total neoadjuvant therapy, which is defined as systemic therapy and either short course radiation or long course chemoradiation. Surgery comprised total mesorectal excision with intraoperative gross pathology assessment, and patients with metastatic disease at diagnosis were not included in this study. Our data was acquired from the electronic health record at MD Anderson using Foundry, the Palantir Foundry platform, and all data was manually validated. Data points you can see here included MRI data and pathology data that comprised tumor regression grade, or TRG, lymphovascular invasion, and perineural invasion. We also had mutational data for these patients, as well as MSI status. For all the patients included in this study, MRIs and pathology were internally reviewed by MD Anderson radiologists and pathologists with expertise in rectal cancer. Here's a summary of our standard statistical methods that we use for analysis. Regarding demographics, patients in the EMVI positive and negative group did not differ significantly with respect to age, gender, race, or ethnicity. The vast majority of patients included in this study were microsatellite stable, that you can see in the bottom row. Regarding preoperative MRI data, so patients with EMVI were more likely to have a higher MRI T category, namely T3 and C disease and T4 disease. And they're more likely to be radiographically node positive. The rates of pelvic sidewall nodal involvement did not differ between the two groups and were approximately 20%. Regarding treatment details, patients who had EMVI were more likely to have total neoadjuvant therapy compared to the patients without EMVI. Margin status, the negative margin rate was excellent in both groups, and the rate of mesorectal excision was comparable. Regarding final pathology details, patients with EMVI were more likely to have a higher pathologic T and N category. Finally, with respect to TRG, perineural invasion, and lymphovascular invasion, patients who had EMVI were more likely to have a higher TRG grade, and more likely to have perineural and lymphovascular invasion on final pathology. This is just a graphical representation of pathologic TRG after neoadjuvant therapy. Again, patients with EMVI were more likely to have TRG 2 or 3, and the patients who are EMVI negative were more likely to have a TRG or higher rates of TRG 0. Regarding patients who are clinically T3 and T4, the patients who were EMVI positive were less likely to be downstage on final pathology, more likely to be pathologically T3 or T4 tumors. Similarly, patients who were clinically node positive were more likely to be pathologically node positive if they had EMVI. Regarding mutation status, here you can see our KRAS and BRAF mutation status. Patients did not differ with respect to KRAS mutation profile with respect to EMVI. The rates of BRAF mutation in EMVI positive patients were slightly higher, though this did not reach statistical significance. Finally, regarding survival, so recurrence-free survival did not differ significantly between the two groups, with a median follow-up of 24.6 months. Further, when you break this down by type of neoadjuvant therapy that each subgroup received, there's no difference in recurrence-free survival among all the groups, even with respect to chemoradiation versus TNT. The study should be interpreted in light of some limitations. Again, this is a single institution analysis. The study period also spans multiple different treatment eras, including the incorporation of total neoadjuvant therapy, changes in TNT regimens over time, and the introduction of watch and wait or non-operative management for rectal cancer. In fact, patients with complete clinical response after neoadjuvant therapy may not have undergone resection and thus weren't included in this analysis. Finally, the somewhat limited timeline of follow-up precludes a more robust survival analysis for these patients. In conclusion, patients with rectal tumors with EMVI are more likely to have higher clinical stage and high-risk features for recurrence, including pathologic node positivity, lymphovascular, and perineural invasion. EMVI is a marker of disease with poorer response to neoadjuvant therapy, even in the TNT era. And these patients may benefit from neoadjuvant treatment intensification, and its use should be considered in this patient population. Thank you very much.
Congratulations on a well-presented study. Pathologic EMVI occurs in about 1/3 of rectal cancer patients and is associated with higher rates of local and distant recurrences and poor prognosis. Other investigators have shown that even in stage 2 rectal cancer patients after preoperative chemoradiotherapy, that EMVI positive cancers have worse outcome and more similar clinical outcomes to stage 3 node positive disease. As shown in this well-done investigation by Bhutani et al., over a 6-year time period of 278 patients, EMVI was noted in about 38% of them, and as expected was associated with higher T stages, higher rates of lymphovascular, perineural invasion, nodal positivity, as well as worse downstaging after neoadjuvant chemotherapy. Interestingly, these worst prognostic factors did not seem to translate into patient outcome differences because the cohorts had equivalent recurrence-free survival, something you postulate is due to the higher rate of total neoadjuvant chemotherapy in the EMVI cohort. The explosion in directed therapies based on MSI status and mutational analysis is radically changing treatment paradigms. Unfortunately, you show no difference in your cohorts here, which really does not open that up. So a few questions. The recently published Kronos study from Spain demonstrated improved tumor regression in patients whose surgery was scheduled more than 12 weeks after completion of radiation. You don't report the time interval from completion of your neoadjuvant protocols here to surgery. Do you have an opinion on whether EVMI positive patients should have a longer time interval before surgery to see if improved tumor regression occurs? Patients with EVMI have also been shown in some studies to have a greater incidence of positive lateral nodes. I think you showed it on there, but it wasn't in what I had reviewed, so that one's been answered. And do you consider EVMI a contraindication for watch and wait for patients that appear to have complete pathologic responses to TNT or neoadjuvant? Thank you for your opportunity to comment on this. Looking forward to your answers.
Thank you, Avni Nupal from MD Anderson. Thank you for your providing the questions ahead of time to help us address some of the questions that you had and reviewing our manuscript so carefully. With regard to the watch and wait, and I think the timing of surgery after finishing treatment kind of plays into that, because as the Memorial Sloan Kettering group has shown before, that the time interval shows you get longer response, and as you mentioned in the Kronos study, they seem to have a better response. That ties in with the other question about can you consider non-operative treatment in these patients? And we look back at another cohort of our watch and wait patients, and preliminarily looking at that, we saw that there was quite a high rate of tumor regrowth, approaching almost 50%. In this admittedly a limited sample of those patients who are EMVI positive and then had initial complete clinical response. And this was greater than the kind of the overall rate, around 20%, which is generally reported in the literature also. So I think there is some room to consider that, but counseling the patients that there is just with the EMVI alone, there's quite a high risk of regrowth and ultimately requiring an operation. And I think that's something that's really important when, in general, reviewing with the patients what the options are going to be when we first meet them, even before they start any neoadjuvant treatment. The timing for patients who are going to undergo resection, I think, is a good question and something we need to look into. and see is there a difference in the median time interval from re-imaging and how that and operation compared to when they finish the treatment. I think that's a good point. And going into the question about treatment intensification, does giving more treatment and giving more time potentially improve that, either through additional treatment regimen, such as FOLFIRINOX, like they did in the Project 23 study, or just additional cycles? I think that's something that needs to be clarified. In general, I'd say a caution about when we're looking at non-operative management. The OPRA study excluded patients who had EMVI, so they would not be really applicable in terms of that randomized trial. And the other two big trials that have come out recently, looking at total neoadjuvant Protégé and Rapido, they did include those patients, but all those patients went on to resection. So it's hard to know, but I think that's definitely something that we need to keep an eye on in terms of being cautious with these patients.
Thank you so much. Any questions from the floor?
Ave, this is a great study, and it's the wrong end of the GI tract for me, so I'm sorry if I'm asking you a dumb question. But when you talk about not responding to neoadjuvant therapy, and then the next idea is to intensify it, I mean, is it not logical to say these guys aren't going to respond, let's just take the tumor out, as opposed to giving them long course neoadjuvant treatment?
Yeah, I think that is all. Then that's still standard of care. As you know, with being on the wrong end of the GI tract, people are very particular about what happens to that surgically. So I think in terms of if we were wanting to pursue some kind of non-operative approach, that would be an area that would need to be looked at, especially for these high-risk patients. But I agree that if they want it, and some fair amount of patients will just say, I just want this out. It's a high-risk tumor. I don't want to find out what happens. So I do think that in those cases, it's reasonable to do the standard treatment and then move on from there.
Do you have any data to demonstrate a correlation between EMVI and ctDNA levels, especially with kinetics with treatment?
That's a good question, something that we're looking at right now. We have looked at what are the ctDNA levels after resection in total neoadjuvant, and have seen that in general it's associated with a higher rate of ctDNA positivity. We don't have quite as much data, but we're prospectively collecting that on preoperative ctDNA and pre-neoadjuvant ctDNA levels and how those go over time.
Thank you so much.
Thank you.
We can call our next speaker. A multi-center derived scoring system to predict survival to hospital discharge following resuscitative thoracotomy, presented by Dr. William Reisinger, and then closed by Dr. Jamie Coleman from Louisville School of Medicine, and then invited discussants, Dr. John Daniela from Advocate Christ Medical Center. Thank you.
Thank you so much. Good morning, everybody. My name is Will Reisinger, general surgery resident from the University of Louisville. It's truly a pleasure to be out here in Southern California. I want to thank all the members of the Western Surgical Association for the opportunity to present our work pertaining to resuscitative thoracotomy. The authors and myself have no disclosures relevant to this study. From an introduction standpoint, the resuscitative thoracotomy really has its roots in the management of penetrating cardiac injuries. However, since its inception, it has been utilized by trauma surgeons for numerous other injury patterns and mechanisms. Unfortunately, although the procedure itself has the opportunity to be life-saving, overall meaningful survival, that is survival with favorable neurologic outcomes, is often cited to be below 10%. This is also weighed with the potential for exposure and injury to providers during the procedure. Given the complexity surrounding the decision to proceed with this intervention, we're very fortunate that the Eastern Association for the Surgery of Trauma and the Western Trauma Association have attempted to create guidelines that center on mechanism of injury, absence or presence of signs of life, and duration of pre-hospital CPR in terms of helping clinicians decide when to proceed with intervention. Unfortunately, despite these, it's a challenging decision to make in the trauma bay, and it varies significantly based on individual providers and institutions. When you look at some of the current guidelines and indications, such as mechanism of injury, although penetrating thoracic injuries are often seen as the ideal candidate, and in some circumstances, the sole candidate for some providers, it's well known that there are survivors following blunt injury as well as extrathoracic injury. In addition, signs of life, which we tend to associate with the salvageable life or the presence of life in a patient presenting without a pulse, has been a key indication in determining the procedure. We use things such as agonal breathing, spontaneous movement, cardiac electrical activity, as well as pupillary response to determine when these are present. In addition, currently, cardiac ultrasonography is also used to evaluate for cardiac wall function as another measure of signs of life. Unfortunately, obviously in the pre-hospital setting, and oftentimes in the acute evaluation in the trauma bay, this technology can be limited. And lastly, numerous studies have emphasized the importance of the duration of pre-hospital cardiopulmonary resuscitation, favorable outcomes following resuscitative thoracotomy. Most guidelines cite 15 minutes for penetrating injury and 10 minutes for blunt injury as thresholds for when these procedures should be performed. However, unfortunately, oftentimes the duration of pre-hospital cardiopulmonary resuscitation is either unknown or simply estimated by pre-hospital providers, which limits its utility in determining when to proceed with intervention. For these reasons, we sought to create a survival-based scoring system that a single provider could use in the often chaotic trauma bay to make a decision regarding resuscitative thoracotomy. We wanted it to incorporate unambiguous variables that were easily identifiable and were proven via survival statistics to be associated with survival. Ultimately, we wanted these to be combined into a single clinically useful metric that could be used. To accomplish this, we used the AAST Aorta Registry, which is a multi-center, prospectively maintained database from trauma centers across the country that accounts for resuscitative thoracotomies as well as endovascular occlusion of the aorta. We isolated resuscitative thoracotomies from 2015 to 2021 from approximately 50 trauma centers. We looked at a survival timeline, evaluated procedural and hospital complications and outcomes, and ultimately performed an analysis between survivors and non-survivors to establish the scoring system. Although 1,752 patients undergo resuscitative thoracotomy, you can see that the drastic drop in survivability is evident. Patients survive beyond 24 hours in approximately 10% of cases, and while this is clinically useful, the more meaningful impact is how many patients are making it to leave the hospital. And you can see that percentage drops all the way down to 4.79%. From a complication standpoint, the fear in performing this procedure in the trauma bay is that there can easily be iatrogenic injuries to the phrenic nerve and esophagus. And what we found is that actually was not evident in survivors. In the global population, there were 2 to 3 instances of esophageal injuries. However, other complications are minor. Patients suffering retained hemothorax or empyema requiring surgical intervention was less than 10%. Patients had spinal cord ischemia in only 1 instance, presumably from the procedure. Unsurprisingly, patients who undergo resuscitative thoracotomy mandate further operative interventions such as thoracotomy and exploratory laparotomy, with less often utilization of angioembolization and craniotomy craniectomy. Much like any severely injured trauma patients, these patients go through a rather prolonged and complicated hospital course. Incidences of acute kidney injury is around 30%, with over half of these patients requiring renal replacement therapy. Pneumonia is seen in 1/3 of patients, and ultimately 1 in 5 of these patients suffered acute respiratory distress syndrome. Patients were in the hospital on average of about 3 weeks, spending 2 weeks in the ICU and on the ventilator for greater than 10 days. However, importantly, patients had relatively favorable outcomes neurologically at discharge. GCS scores were 15 for most patients, and on the scale of 1 to 5, the Glasgow outcome score had a median value of 4, which suggests patients do have some disability, but they're able to go about their daily lives without any assistance. Lastly, which is important, is that not only are 5% of patients going home, but only half of those patients are actually being discharged. So my apologies. 5% of patients are leaving the hospital, but only half of them are going home. The remainder are going to rehabilitation centers or skilled nursing facilities for ongoing management. When it came time to identify candidate variables to include in our scoring system, we did a direct univariate analysis between survivors and non-survivors. And although age, when treated as a continuous variable, shows no difference between survivors and non-survivors, you can see that when you set a cutoff such as 60 years of age, almost all of the survivors are under this point. There was only 1 survivor in the whole database over the age of 60, and they were 61 years of age. Injury severity score and laboratory evidence of shock were slightly higher in the non-survivors. And unsurprisingly, pre-hospital CPR, in addition to active CPR on arrival to the hospital, was more common in non-survivals. From a duration of CPR standpoint, Although pre-hospital CPR was shorter in survivors at 7.5 minutes, there was survival despite 28 minutes of pre-hospital cardiopulmonary resuscitation, which again limits credence to the ability of defining strict cutoffs based on these values. Signs of life were more common in survivors as well. From a mechanism standpoint, historically, penetrating injury has shown a association with survival. However, on univariate analysis, that was not true in this population. And interestingly, from a primary source of hemorrhage, although most people see this as an intervention for thoracic injuries, over 60% of survivors had primary bleeding sites outside of the chest. And oddly and somewhat surprising is that when you look at extremity injuries in particular, around 20% of people presenting with primary bleeds from extremities survived a hospital discharge following this intervention. Importantly, it doesn't appear that there is a difference in survivability depending on who does this procedure. Once these univariate analyses identified candidate variables, the goal was then to perform a logistic regression to verify that these were in fact survival predictive. And what we found that age under 60, responsive pupils in the absence of CPR on arrival, as well as penetrating injuries, were actually survival predictive. Organized cardiac rhythm, as well as spontaneous movement, were not associated with survival in this model. The next step was then to take these variables and to create a scoring system that could be easily calculated by providers in the trauma bay. And what we utilized was age under 60, reactive pupils on exam, which serves the function of signs of life, and the absence of CPR in progress on arrival and a penetrating injury. The absence of CPR on arrival acknowledges the importance of cardiopulmonary resuscitation and long-term outcomes in these patients, but it avoids the ambiguity of duration, making it an easy variable to capture by clinicians. And oddly, although penetrating injury was not associated with survival on univariate analysis, we included it in the logistic regression model based on historical evidence, and it does turn out that it still predicts survival and is included in the scoring system. When you calculate the score for all the patients in the database, you can see that it approaches a normal distribution with the most common score of 2 with lower ends on either side. The next important aspect becomes, well, you create the scoring system, how does this predict survival? How does this change things? And what you can see is that there's an incremental increase in survival to hospital discharge based on your score, ranging all the way from 0.39% with a score of 1 to upwards of 22% if you hit 4 out of 4. How this changes clinical management is important. If you have a patient coming in who has a score of a 4 and they have a 22% chance of survival, that appears to be an ideal candidate for resuscitative thoracotomy. Likewise, a patient with 3 merits intervention. However, on the other end, if you have a 0 or a 1, your likelihood of benefiting from the intervention is next to 0. The challenge from a clinical standpoint becomes, what do you do when you have a score of 2, which unfortunately is the most common score that patients get? And this really hints at the importance of individual provider preferences and individual provider experience. When you look at the 4 variables we used, although almost all the patients with a score of 2 were under the age of 60, the remaining 3 variables were relatively dispersed, which indicates that using one variable in isolation to make a decision regarding this procedure is almost impossible. This should certainly be evaluated in the setting of severe limitations. Firstly, although the database is prospectively maintained, this is a retrospective observational study. It can have inconsistent documentation, and the lack of granular details really limits your ability to delve further into specific cases. We did not use cardiac ultrasonography as it was not captured in this database, and this is only at level 1 trauma centers. In conclusion, the scoring system provides another opportunity for us to create a useful metric that clinicians can use to identify not only potential candidates for resuscitative thoracotomy, but provide you with some authentic prognosis post-procedure, what the likelihood of a patient will make it to hospital discharge. And with that, I appreciate all my co-authors' support and look forward to questions and comments from the audience.
I want to thank the Western Surgical Association for allowing me to discuss the paper and the authors for getting me the manuscript in a timely manner. What they've attempted to do was simplify the decision-making process on who gets a resuscitative thoracotomy using a simplified scoring system. Using the AAST aorta study, the prospective study data, they've come up with those 4 criteria to try and help simplify the chance of survivability in someone who gets a thoracotomy. The criteria used eliminate the need to ascertain the pre-hospital resuscitative measures or the timing, which is great because it's haphazard and subjective at best. So the criteria that you used I only have 3 questions, and they are, that study that you're using the data from, the AAST prospective aorta study, was used originally to compare resuscitative thoracotomy open to Reboa. So do you think that extrapolating that data to the scoring system is valid? 2, there's no data on ultrasound or FAST for evaluation of the cardiac motion on the criteria. Did the data that you used have that in there and you just didn't use it, or was it not in there at all? And if it wasn't in there, I refer back to question 1. Do you use this criteria at your institution? And if so, do you have any data to further validate the scoring system? Thank you.
Thank you so much. Yes, the time is a problem, right? I mean, we all know this. I joke all the time that, you know, the area right outside the trauma bay has to be the most deadly zip code, right? Because everyone just lost pulses, right? Like just right outside. So the ambulance bay, you know, we know. And that's part of the issue, is that our current published criteria depends so much on that. And we're asking a lot of our EMS and pre-hospital colleagues to be accurate with that. And let's be honest too, when you're in the back of the bus, it's a bumpy ride, they're trying to feel for pulses, you know, it's just not accurate. So thank you for bringing that up. It's a problem we all deal with. So secondly, it's a good point. The aorta database was really designed for the Reboa versus ED thoracotomy. We do know that 39 patients out of the 1,700 and some change that we did get Reboa. Out of those, 3 survived, 36 did not, which obviously is so low. There's no use in trying to even incorporate that into what we're doing. That being said, although the ultrasound data was not in there consistently enough to use, I think that's part of our problem, is that in practice, it's not consistently used across centers. And I think that's something that when we talk about signs of life, it's just, we're using it inconsistently and we shouldn't be. In other words, we should be using it more consistently as just like we use for pupils, signs of respiration is a potential sign of life. At our institution, we do use it. So when a patient comes in and, you know, whether they're within the timeline or not, if it's questionable, we do use it. And, you know, I think it goes back to, you know, is it valid? I do think the database overall gives us good data on what we're really trying to get at for this, which is really looking at the natural history of ED thoracotomies with a large number of patients, which is what you need when you're trying to identify survivors, which we know occurs at a low rate. And overall, we're not currently using this criteria at Louisville. I think what Dr. Reisinger highlighted, which I think is important, is you get to those 2 points. The 4 points are kind of an obvious. The 2 points, which 2 points? Does it matter? I think the age does matter. But I think the thing for me that was interesting, when you look at the Western trauma algorithm, injuries to extremities is lumped in together with an extremity to the head and neck. And the criteria currently published is less than 5 minutes for pre-hospital CPR as an indication to do an ED thoracotomy. When actually you look at this data from the AAST database, and you see that it's almost a 20% survival rate for extremity injuries. So that to me, I think is actually kind of the real novel addition to our literature that can actually help drive change. And I will say we have had that discussion within our group, and not necessarily using extremities outside of 5 minutes as a reason to not do ED thoracotomy. So that is where our practice has changed a little bit. Thank you.
Hi, Sherry Wren.
Hi, Dr. Wren.
Stanford. You actually, your last point kind of addresses what I wrote down. So the extremity injury to me is really interesting because you're also spanning a point in time when tourniquets were not being used. So are these junctional injuries? Because in the modern day, to me, it's sort of inconceivable that you could have an extremity injury that would result in traumatic arrest, unless it's been out there a really long time and you probably shouldn't be resuscitating at that point. That wasn't junctional. So any data on that?
Nice presentation, Jamie Moore from Denver. There's a couple points I think need to be recognized. First of all, the aorta database is voluntary. It's not comprehensive. It's not prospective. If you look into the Western Trauma Association prospective study, which I think is the only one ever done, you'll see exceptions to your rules. When we create these futility index, it's got to be 100%. While you claim that only 5% survival, that's 1 out of 20. If that was your kid or your mother, you'd probably want the exercise done. Furthermore, Reboa is an alternative. I really have difficulty accepting the risk to the provider, but Reboa is an alternative. It's a lot easier to initiate resuscitation and then stop it once you see the response. You may be aware at this point, there are 3 publications now, including one of ours, that show that Reboa has superior resuscitation outcome to thoracotomy outside the chest. So that's an option, is to use Reboa if you don't want to get your fingers dirty and worry about sticks of patients with various viral diseases. Finally, an area that is controversial, but I believe is critical, is the salvage of organs. Both LA County and our group have reported patients with asystole surviving resuscitated thoracotomy in which we've obtained organs for transplant. And this adds a whole nother element to societal obligations and what we should do as trauma surgeons. Thank you.
Brazel from Portland. I do have a specific question that's related to inclusion of age, especially for something that is as high stress and difficult as this. The information needs to be easily obtained right when the patient comes in. And that was highlighted by the fact that you have a 61-year-old survivor. Now, without revealing my age, I'm very clearly not 20, but I challenge you to guess my age within 1 year. And so how do you suggest applying the age criteria when we don't know the ages of these trauma patients when they come in? Thank you.
Thank you.
Jerkovich, Sacramento. First of all, wonderfully presented. Thank you. Your presentation demonstrated an understanding of the nuances of the difficulty of this problem. And by that, I mean the issues of what is futile. We heard Jean a little bit talk about that. We don't really have a good definition for futility. The difficulty in determining signs of life, what does that mean? How do you even know that the pupils are reactive? That's a completely subjective event as well. Nobody's doing the pupil measurements in the ED like we do in the ICU. So the nuances that are involved with this are spectacular, and you've tried to sort them out. The only question I have for you, Jamie, and the group is, you mentioned this, the people who get 2 points, right? How carefully have you looked at that entire group? What's their age distribution? Are they younger? How are they injured? Are they more likely penetrating? Which of the 2 of the 5 is the 2 most important? Can you parse out a little bit more of that most difficult group that just gets 2 points? So thanks for the presentation.
Thank you so much. Thank you for all the questions. Regarding the junctional injuries, short version is we don't have that data. Again, this is the downside of using a registry database in that it's not designed necessarily for this question. We're attempting to extrapolate it, but it's a very good point. But I will say, anecdotally, it's interesting. We had superficial femoral artery patient injury, came in arrest, and was outside the 5 minutes. We did do the ED thoracotomy, got him back, and he went home to discharge. So believe it or not, we do not have ShotSpotter, for instance, in Louisville. Believe it or not, you can have some downtime before someone calls 911, depending upon the situation in which someone's injured. So I do think that even if it's not junctional, we do have patients that bleed out from purely extremity injuries. Regarding, Dr. Brazel, yes, age. And you bring up a fantastic point, because you're right. We're not able to guess within one age. I mean, there are times that we guess I mean, we had a patient the other day, we're like, oh, we think he was a teenager. He was in his 30s. You just don't know for these. And I think more often than not, a lot of this is just thought provoking. It's helping to bring in Dr. Djurkovic's points. It's the point of trying to bring in as much knowledge as you can, knowing that it's all nuanced, knowing that a little bit here and a little bit here helps add to our gestalt, helps add to our clinical decision making. And this was an attempt to try and give points for people to focus on and look at. And I think that that is an extremely important point. It's 50-50 sometimes, even if you have a name for a patient, much less an age. So I think you bring up an excellent point there. And Dr. Djurkovic, 100%, you nailed it. 2 points, that's kind of part of the problem. When we looked at it, the only thing that came up with the 2 points for the survivors was age, actually. For the second point, it was pretty evenly distributed. There wasn't statistical significant difference, maybe a slight edge for the pupillary response. But again, I think it's an overall gestalt. A lot of times when you're in the trauma bay, as we know with trauma surgeons, we are given very limited information and we are working within a very limited time span. So you're trying to make quick decisions based on what you can. And I think overall with the 2 points, we still have a lot more work to do for that. Thank you all so much.
Thank you so much. We go to another trauma-related presentation, management of combined traumatic brain injury and solid organ injury. Does trauma level make a difference? That will be presented by Ayesha Tariq. Member closer will be Dr. Nicholas Sheets. And then we will have the discussion by Dr. Mingli Wang from New Mexico. Thank you.
Good afternoon, everybody. I'm actually a medical student at UC Riverside School of Medicine, and I will be presenting on behalf of the physicians listed. So we're going to be talking about the management. Oh, and thank you to the WSA for inviting us to speak. Oh, no disclosures. So let's talk a little bit about the background of our project. I'm going to start with the Orange Book. So the Orange Book is actually the resources for optimal care of the injured patient. And this is created by the ACS, Committee on Trauma. There are guidelines defining requirements for the 4 national trauma center levels. In 2014, the Orange Book was actually revised, and it designated that level 1 and level 2 trauma centers provide equivalent resources. And this includes, but not limited to, equal availability and utility of angio and laparotomy. And this quote I took directly from the Orange Book. Level 1 and level 2 trauma centers are expected to be clinically equivalent except for replantation. Okay, then, so our population is patients with TBI and SOI, so the combined injuries. These have not been yet compared between level 1 and level 2 trauma centers. And we're interested in this population because of the pathophysio. So it's very complex in these patients because there's extracranial hemorrhage and hypotension that's well documented in the literature, and this increases mortality in TBI patients. And this induces or worsens secondary brain injury. And what that is a cycle of edema and inflammation, and it occurs days to weeks following the severe TBI, which can cause a loss of cerebral vasoregulation and can involve really significant areas of the brain. And the medical management of that type of a TBI, or TBI in general, is attenuating that secondary brain injury. The expertise and availability of different methods of hemorrhage control, which is angio versus laparotomy, may vary clinically, but just the changes in the revision in the Orange Book from 2014. I'm going to talk about a little bit, just a few studies that we looked at from before 2014. Again, that's before the revision. So the first one, yes, that one is it's level 1 versus level 2 trauma centers and outcomes-based assessment. This is a study, it's a multi-center retrospective cohort analysis, and this was done in Ohio. And they looked at patients that were directly transported from the scene to the ER to level 1 or level 2 trauma centers. And this was done from 2003 to 2006. And what they concluded was that level 1 trauma centers had better functional outcomes and improved survival than level 2, including in-hospital mortality. And this is, again, what we expected, because again, it's before 2014. Second study we looked at, I looked at the National Trauma Data Bank at adults with an injury severity score over 15. And they looked at data from 1994 to 2003. And they concluded, once again, level 1 has better survival than level 2 trauma centers. And the third study we looked at compared the ACS verification and state designation on trauma center outcomes in level 1 and 2. And when they were adjusted from mortality, it showed similar outcomes. Okay, and this is literature coming from after 2014. So the first study that we looked at used the Trauma Quality Program Participant Use File, which looked at data in 2017. This was a few years after the 2014 version of the revision of the Orange Book was implemented, to give a few years for the trauma center to kind of keep up. This concluded that level 2 centers and level 1 centers had similar adjusted mortality. And the third, the second study that I looked at, this was actually a pretty big systematic literature research, and it used 6 databases all the way up to 2020, bless you. And they looked at 25 studies using meta-analysis at outcomes across different levels of trauma care. And these looked at populations with severe specific injuries. So just to kind of quickly go over some numbers that the systematic review came up with. So in-hospital mortality studies after 2014 were mixed, but the majority was seeing that there was no difference in mortality in level 1 versus level 2. 34 of those studies were reported in-hospital mortality, 11 out of the 34. Level 1 had a lower mortality level, and then 9 out of 11 compared the two, and then 22 of the studies reported no difference. So what we did is our study objectives were to compare the differences in management strategies for hemorrhage control between level 1 and 2 in patients with combined TBI and SOI. It's the primary outcome. The secondary outcome that we studied is we wanted to evaluate differences in mortality and measures such as length of stay in hospital stay, the time. We use univariate analysis using chi-squared for categorical variables and independent t-tests for continuous. We further looked at subgroup analysis and different TBI severities. The way we defined it was mild to moderate with an AIS of less than or equal to 3 and GCS of greater than or equal to 9, and severe AIS greater than or equal to 2 and GCS less than or equal to 8. And then SOI grades, we looked at the AIS, and as you can see, we separated by low, moderate, high. And then we also looked at hemodynamically stable patients. And then we continued with multivariate regression analysis and case-controlled matching. This is the algorithm that patient selection algorithm. So if you follow it all the way through, by the end, we looked at TBI plus SOI diagnoses, included 112, but then we looked at adult mechanism, included those, trauma level 1 or 2, and then the total number of patients, level 1 is 32,000, level 2 is about 15,000. Okay, so let's look at the results. So the demographics and the trauma. As you can see, the demographics are listed to the left, and then there's a level 1 column, level 2 column, and the odds ratio with the p-value. So just to go over a couple, level 1 saw higher African American in level 1 trauma centers, and it also saw higher injury severity scores, which is kind of expected because it's level 1 trauma centers. And the mechanism, you can see we looked at several of them, and ones that are bolded are what we see as statistically significant. Should have mentioned that on the right side. We can look at, auto-related, you got 53% versus 45% level 1 and 2, and so on and so forth. Okay, and then we looked at severe TBI. So we looked at 37% in level 1 and 35% level 2. And that was what we saw statistically significant. There's a caveat to that. And then we looked at SOI location. We looked at liver, kidney, spleen, and liver and kidney showed the biggest difference between level 1 and 2. And then SOI high grade, highest grade, L to moderate, to low to moderate to high grade. Okay. The hemorrhage strategy, so the SOI hemorrhage strategy intervention, as you can see, the non-operative or no intervention in the laparotomy showed significance. And what we're going to do, we did next was further subgroup what we saw in the TBI, SOI, hemodynamically unstable. So this first graph is looking at the hemorrhage control management across TBI severities. As you can see, the stars are noting that it's statistically significant. Mild, moderate TBI, you can see there's a difference between level 1 and level 2. In non-op and lap, and in severe TBI, the same thing. We see significance in non-operative and laparotomy. And then we looked at solid organ injury severity. We saw similar results in level 1 and level 2. As you can see, the star low grade, moderate grade, and high grade in non-operative and laparotomy. And then we looked at hemodynamically stable patients. And again, we saw significance in non-op and lap. Okay, then we further we did logistic regression, and what's listed is a level 1, the positive association with the use of laparotomy. There's a list of factors on there, and then level 2 is positively associated with non-op management with these factors that are listed. We looked at angio too, but this was associated, had no verification in the final model. We went to further match for age, gender, injury severity scores, hemodynamic stability in TBI, severity and SOI grade. And you can see once we matched, we did not see any significance in non-op angio or laparotomy. For outcomes, we looked at mortality, hospital events, which include complications, length of stay in the ICU or hospital overall. And now we further looked at mortality. So that was our secondary outcome. We did a logistic regression, and as you can see, the level 1 and level 2 trauma centers are not associated with mortality. So their verification status is not associated. And we looked at the factors listed. We went ahead and matched 2, and that also shows no statistical significance, 16.8 versus 17.2, level 1 versus level 2. And the reason we matched was to see if there was any sort of influence on the outcome of mortality between level 1 and level 2. Okay, so just to kind of wrap up with the discussion, the differences that we saw between level 1 and level 2 centers, specifically that we saw non-op management and more in level 2, and then laparotomy in level 1. We went ahead and looked at that even closer by subgroup analysis, and we looked at specifically how to control during hemorrhage events in level 1 and level 2. And when we did that, we saw no difference in mortality. We further looked at, we used logistic regression to further look at this data, and it was similar results to the first, the level 1 and level 2, with level 1 being, having more lap events and non-operative in level 2. And then the matching kind of just disintegrated that data, meaning that it just showed that there was no real statistical significance. Sorry, I have one more slide. Again, level 1 and level 2 showed similar outcomes. For unadjusted, the mortality was higher in level 1, but when we adjusted, the length of hospital stay, ICU stay, and the hospital complications showed an increase. But once all of these were adjusted and matched, we showed no association in trauma level mortality and no statistical significance. And the complications, we looked at several complications. I won't go into details with all of them, but some that we looked at was cardiac arrest, UTI, pulmonary embolism, AKI, DVT, sepsis. There were some limitations. It was a retrospective review, and the way that we define TBI and categorize SOI, And statistical significance does not necessarily equal clinical significance. And conclusion again is level 1 and level 2 show similar outcomes. There's no difference in management between TBI and SOI injuries. And that's it. Thank you. That was scary.
Thank you. As faculty at the only level 1 trauma center in the state, I'm faced with the struggle of lack of bed availability and ED crowding. The study is relevant to me and others who wonder whether we should accept that polytrauma patient with combined TBI and solid organ injury in the middle of the night. It answers the critical question of whether outcomes of care will be different between level 1 and 2 centers, and your study suggests there's no difference in mortality. But I have 2 reservations that I'd like you to address. One, initial management of hypotension in TBI and solid organ injury patients is critical beyond mortality, such as quality of life. Well, patients have long-term disabilities that lead them to needing a feeding tube, cognitive and motor deficits that lead them to discharge to a skilled nursing facility rather than home and independence. Know that you've shown the outcomes related to mortality are no different, but how about morbidity? Were you able to tease out whether similarly injured TBI patients ended up with disabilities that led them to discharge to home versus rehab versus skilled nursing facility versus long-term care facility? I believe this information is clinically important to the quality of care to patients and providers. Number 2, interestingly, IR was more often used in level 1 despite equivalent patient variable and factors in solid organ injury. Do you have an impression of the differences in morbidity among these patients? As a trauma surgeon, I have very low threshold to perform a splenectomy on polytrauma TBI patients, even if grade of splenic injury is low. I choose surgery with the thought that each episode of hypotension in the IR suite or ER is a hit on their brain that will likely greatly impact their disability from their brain injury. Were you able to compare the outcomes in terms of TBI recovery in this subgroup of IR managed patients between level 1 and 2 centers? I thank the authors for supplying me their manuscript in time for my review prior to the meeting. I'm very impressed by the mentorship of your medical student in research, and I thank the Western Surgical for giving me the opportunity to review this important study to improve quality of care for our complex trauma patients.
Yes, thank you. I'd like to first thank the Western Surgical Association for allowing us to present our research here. I'd also like to thank Aisha Tariq, the 4th-year medical student at UTR School of Medicine. She's had a very busy month, very busy day, and she is applying for a surgical residency right now. I'd also like to thank my colleagues. Without them, these types of research papers out of our program could not happen, especially Dr. Condell for this paper. And lastly, thank you, Dr. Wong, for reviewing our paper, supporting it, and giving us some insightful questions and comments. Thank you. TBI management, solid organ injury, is a very complex very complex issue to deal with. There's a lot of management issues that must be considered. Regarding your questions, comorbidities and outcomes among our patients, I do agree that something other than mortality is important to look at as far as how we're managing our patients. We did look at in the with the National Trauma Data Bank and the hospital events such as PE, surgical site infections, and so forth is available. My team did look at that. When we did match our patients based on their TBI, ISS, hemodynamic disability, there were no difference in that regard. But as far as other things such as feeding tubes, tracheostomy, discharge disposition, such as a skilled nursing facility or LTAC, I think those are very important. Unfortunately, with the National Trauma Data Bank, we don't have long-term outcomes, but those sort of disposition things are available. I think that's something that we can look into, so thank you for that insightful comment. In regard of laparotomy versus non-operative management and angiography, comparing the outcomes between level 1 and level 2 trauma centers, that is also our question too. this is, in talking with some of my colleagues, this is something we've already started looking into, and we will be looking in that in the future, and possibly submitting an abstract to another conference, or maybe this conference for next year, and possibly a paper. On the surface, as far as mortality, there is no difference when comparing level 1, level 2 for angiography, laparotomy, or non-operative management. But again, back to your first question, looking at comorbidities, disposition, this would be very important for us to look at. So thank you for that.
Ms. Dr. Moore?
A very nice presentation. But I think there's some major issues here that many in the trauma community recognize that really is the elephant in the room. And I think that one of the major oversights of the Committee on Trauma was to equate clinical outcome in a level 2 versus a level 1 without volume criteria. In fact, the volume criteria for level 1 are, I think, unjustifiably low. The Harborview group 10 years ago demonstrated very clearly that outcome didn't improve until you exceeded 650 ISS per year. The problem with the Committee on Trauma assigning equivalent care to level 2 is that, as you well know, that allowed for-profit enterprises to move in and develop trauma centers with low volume that reduce the volume into level 1. So consequently, we've diluted out trauma, so we don't have high volume trauma centers anymore. The destructive course has been clearly demonstrated in Florida, Texas, and in Colorado. So my point would be, instead of stratifying by level, the more important stratification is by volume. Every year we talk about volume. I would suggest that you should look at outcome based on volume. Furthermore, I suggest that the outcome of level 1 versus level 2 goes beyond clinical care. It goes to trauma education and it goes to trauma research. How many of these level 2s have published standards that have changed care in the United States? Most of the traditional care we've provided and the guidelines we use in our country have come from large volume level 1 trauma centers and urban centers. So while your study, I think you've done the best you can, I think it's imperfecting and imprecise and really defining our issue of the impact of volume on outcome. Thank you.
Yes, thank you, Dr. Moore. Very important. I think that's be a good, like, hospital level study, multi-institutional study to look at that. But unfortunately, yeah, with the National Trauma Data Bank, as you're aware, we don't have that sort of information. But thank you, very insightful.
Any additional questions from the floor? Thank you.
All right, thank you.
Our next speaker is Dr. Raimar Turangan, who will present laparoscopic type 4 hiatal hernia repair in elective and emergency setting, clinical presentation, treatment, and outcomes. The member closer is Dr. Farazan Banki, and invited discussants, Dr. Fareed Katie from Louisville. Thank you.
Good afternoon. My name is Raimar Turangan, and I am a third-year medical student. Thank you for the opportunity to present our work. We have no disclosures. Clinical presentation outcomes of type 4 hiatal hernia repairs may differ in elective and emergency settings. We aimed to compare the presentation and outcomes of patients who underwent laparoscopic type 4 hiatal hernia repair and to identify the optimal treatment in an emergency setting and factors associated with emergent presentation. We conducted a retrospective study of patients who underwent laparoscopic type 4 hiatal hernia repair in elective and emergent settings over a period of 8 years and 8 months. All procedures were performed by the same surgical and anesthesia team. The most common procedures were Toupet fundoplication and fundopexy. This video shows a laparoscopic reduction of an incarcerated type 4 hiatal hernia with intrathoracic stomach, herniated omentum, and transverse colon. After reduction of the colon, omentum, and stomach, mediastinal esophageal mobilization was performed. The hernia sac was excised. Tension-free esophageal length was obtained. Crural closure was performed using interrupted stitches. The right crus was released. And mesh was placed. A fundopexy was performed by placing interrupted stitches starting right below the gastroesophageal junction between the greater curvature and the left lateral diaphragm and the upper abdominal wall with the aim to anchor the entire fundus into the abdomen and to prevent recurrence as seen in this picture. Outcomes were assessed by perioperative complications, length of stay, the number of same-day surgeries and elective procedures, 30-day mortality, and post-operative ED visits and readmissions. Same-day surgery was planned in all elective procedures with ASA 2 and 3. Observation was defined by less than a 24-hour hospital stay and inpatient as 2 nights or more. Over an 8-year and 8 months period, there were 776 laparoscopic hiatal hernia repairs at our center. 265 primary type 4 hiatal hernia repairs were included. 78.5% were elective and 21.5% were emergent. This table shows the demographics and hiatal hernia characteristics. Patients who underwent emergent procedures were older, had lower BMI, and higher ASA. The most common chief complaint in elective procedures was dysphagia in 26.4% versus abdominal pain in 33.3% of emergent procedures. The most common presenting symptom was regurgitation in 76.4% in the elective procedure group versus anemia, melena, and hematemesis in 57.9% of the emergent procedures. All elective procedures, around 96.5% of emergent procedures were performed laparoscopically. In the emergent group, there was 1 conversion and 1 transabdominal repair. There was no difference in type of procedures, operative data, and type of anesthesia between the 2 groups. Overall, 30.8% of elective procedures were performed as same-day surgery. The length of stay was longer in the emergent group. This table shows the demographics and hiatal hernia characteristics in patients planned and performed as same-day surgery versus planned and not performed as same-day surgery. Out of 83 patients planned as same-day surgery, 78.3% were performed as same-day surgery. Age, sex, BMI, ASA, and size of hiatal hernia were comparable between the 2 groups. Out of 26 intrathoracic stomach repairs planned as same-day surgery, 96.2% were performed as same-day surgery. In the group performed as same-day surgery, there were more fundopexies. In the group not performed as same-day surgery, there were more fundoplications. In the group performed as same-day surgery, opioid-free anesthesia was used in the majority. And in the group not performed as same-day surgery, opioid-based anesthesia was used in the majority. Reasons for transition from planned same-day surgery to observation and inpatient in 18 procedures that were not performed as same-day surgery are shown in this table. Out of these 18 patients, 50% transitioned to observation. The most common reason was patient preference. 50% were transitioned to inpatient, and the most common reasons were abdominal pain, ileus, and shortness of breath. Overall, in-hospital complications were comparable between the elective and emergent procedures. Postoperative venting gastrostomy for gastric distension and atrial fibrillation were higher in the emergent procedures. There were 2 retained Penrose that required laparoscopic reoperation for retrieval, and 1 gastric leak that required laparoscopic tape back and repair. Blood transfusions were higher in the emergent group. All transfusions were for anemia, except in 2 patients. One had postoperative bloody pleural effusion requiring a pleural drain, and one had mediastinal hematoma requiring VATS and mediastinal drainage. None had intraoperative bleeding requiring transfusion. In the emergent group, there was 1 conversion. 30-day mortality occurred in 2 emergent procedures, one because of fulminant heparin-induced thrombocytopenia and one from myocardial infarction. Symptomatic recurrence requiring reoperation occurred in 4.9% of all procedures at a median time of 24 months. There was no difference between the elective and emergent procedures. There were more recurrences in the Toupet group versus 1 in the fundopexy group, but it did not reach statistical significance. This table shows emergency department visits following discharge and readmissions in patients performed as same-day surgery versus not performed as same-day surgery. Emergency department visits and readmissions were comparable between the 2 groups. Emergency department visits after discharge were required in 10.8% of patients who had their procedures performed as same-day surgery. The most common reason was abdominal pain. Readmissions were required in 9.2% of patients performed as same-day surgery, and the most common reasons were abdominal pain, chest pain, and shortness of breath. Clinical data and diagnostic studies in emergent procedures are shown in this table. Clinical evidence of obstructive gastric volvulus was seen in 86%. Leukocytosis was seen in 46.9% and lactic acidosis in 63.6%. Obstructive gastric volvulus was seen in 32.7% on CT scan and 24.5% on upper endoscopy. 20% of patients underwent CT angiogram to rule out pulmonary emboli, and it was negative in all. None of the 265 patients in our series had a pulmonary embolus in the 30-day postoperative period. This table shows the types of interventions prior to surgical repair and the duration to surgical repair in emergent procedures. Preoperative nasogastric tube placement was attempted at the bedside in 5 patients with evidence of obstructive gastric volvulus on CT scan, and it was successful in all. 13 were attempted endoscopically, and 84.6% of those were successful. Median time from triage in ED to surgery consult request was 7.9 hours. Median time from surgical consultation in the ED to arrival to the operating room in patients without ischemia, perforation, or with obstructive gastric volvulus successfully decompressed by nasogastric tube was 57.9 hours versus 5.5 hours in patients with ischemia, perforation, or with obstructive gastric volvulus not successfully decompressed by nasogastric tube. Comparing the group without ischemia versus with ischemia showed that patients in the ischemia group had a higher ASA and higher numbers of leukocytosis. Lactic acidosis seemed higher in the group with ischemia, but did not reach statistical significance. The operative time was comparable between the 2 groups. There were more nasogastric tube placements and acute kidney injuries in the ischemia group. Length of stay seemed higher in the ischemia group, but did not reach statistical significance, possibly because of low number of patients with ischemia. There were no 30-day mortalities in the ischemia group. We conclude that good outcomes can be achieved in laparoscopic type 4 hollow hernia repair in elective and emergent settings. Majority of elective repairs can be performed as same-day surgery. Factors associated with emergent presentation are higher ASA, intrathoracic stomach, and abdominal pain. Good outcomes can be achieved with prompt intervention in patients with ischemia and perforation. Obstructive gastric volvulus can be treated with endoscopic decompression, nasogastric tube placement, and urgent repair in the majority of emergent settings. We acknowledge the limitations of our study, which include its retrospective nature, lack of preoperative longitudinal follow-up, and heterogeneous assessment of patients in the emergent setting. Furthermore, patients who were seen in our clinic may have presented to another center as emergent presentation, or our patients may have presented to another center with postoperative complications and symptomatic recurrence. Lastly, there's no radiographic follow-up to assess asymptomatic recurrence. Thank you.
Dr. Katie, go ahead.
Fareed Katie from Google. I appreciate the opportunity for the Western Surgical Association to allow me to discuss this paper. Dr. Banki, thank you for allowing me to review the manuscript before this presentation. You have an impressive cohort of patients with complicated paraesophageal hernias, and I was impressed by how high you're willing to push the envelope regarding the care of these patients. I have 3 questions for you. In our experience at the University of Louisville, in caring for patients with engorged paraesophageal hernias or gastric volvulus, we approximate that crura is more difficult frequently because of excessive edema or inflammation. So we find it harder to bring the crura edges together. In your cohort of 57 emergency cases, can you comment on the feasibility of crura reapproximation and how often you used mesh in that cohort? In patients undergoing same-day surgery, can you comment on the number of patients who received a concomitant fundoplication plus epexy, whether it's fundo or gastropexy? And following in that question, one of the main concerns regarding hiatal hernia repair is immediate post-operative recurrence secondary to dry heaving and vomiting for various reasons. Although this is rare, there is a finite chance that this can happen. The main reason patients stay post-op in our practice is keeping them on an aggressive antiemetic regimen, including IV Zofran, Phenergan, scopolamine patches, in addition to opioid-free anesthesia. Despite this, in our cohort of about 1,200 patients, we have had 3 immediate post-operative recurrences, which we would not have been able to manage promptly had they not been inpatient. A fundopexy would minimize this risk, but can you comment on how to mitigate this in your fundoplication cohort of same-day surgery patients? Thank you.
Great. Thank you so much, Dr. Katie, for reviewing the manuscript, for your kind comments, and for questions. Question number 1, crura closure. We were able to perform crura closure on all of these patients in this cohort that you've seen. The maximum release that we do is what you saw in the video. The relaxing incision on the right or left cruise and placement of a PTFE that is well described in literature was not used on any of these patients. So we, for the reoperative procedure, I pretty much put a mesh on everybody. For the first time operation, regardless of type of hernia, emergent or elective, if we are able to bring them together and they're good quality, we call them, there is a right and left grooves very good quality, we do not place a mesh. But if there is any tension and time of crura closure or any bleeding or trauma, we put mesh for reinforcement. As you know, no data has shown that is a big difference between mesh or without mesh. We agree with you that the crural edema can be problematic after this operation, and I think it's manifested as dysphagia post-op. In particular, in patients with fundopexy that they don't have a fundoplication. I think that we try to preserve the peritoneal lining on the right and left grooves, as you know, and to prevent bleeding and edema. We try to bring them together, right and left grooves, but not overlap. And we use a tie knot device to not make them too tight. With all that, 5% of our patients present with postoperative dysphagia, at least one dilation in the first 30 days. How do we deal with it? As soon as they have dysphagia to liquids, we dilate them with savory dilators, and they do pretty well. But I think you're absolutely correct about crural edema, and because of this question, I will add that to the manuscript. We will address that and add it to the manuscript, so thank you for that question. As far as the fundopexy versus toupee and concomitant, doing it at the same time, we believe that you can pexy the distal stomach, pre-pyloric segment of the stomach to the abdominal wall with the toupee. But we also believe that distal pexy does not prevent proximal migration of the stomach into the chest, including with a toupee or a Nissen. The way we do this fundopexy, as you've seen, we start right below the gastroesophageal junction, and we start sewing that to the left upper abdominal wall and the left diaphragm all the way across the fundus. We can't do that if we do a toupee. So none of their patients had concomitant both of those. As far as nausea and recurrence in an immediate post-op, that's a problem, and nausea, as you know, is very well contributing factor. We have a series of measures, it's really multidisciplinary by everybody. So in pre-op, we get Zofran scopolamine match that you mentioned, and everybody gets 1 gram of Tylenol IV before the skin incision. Anesthesia is opioid-free. We decrease the flow from 40 to 20 and the pressure from 15 to 12 during the entire case, so that we have changed our management. And then during the procedure, we try to, when the time gets to do a fundopexy, we inject Exparel to the abdominal wall, everything to decrease narcotic post-operatively. At the end, we do a completion endoscopy. We remove all the air, all the fluid from the stomach. At the end of the procedure, one dose of Toradol is given, and then we have a Valsalva maneuver that we open all the ports to remove all the CO2. Now, post-operatively, we apply Voltaren to the shoulders. We have a protocol with the physical therapy, again, everything to reduce the narcotic post-operatively. And our nurses are very careful. As soon as there is a sign of nausea, they get treated, Zofran, Phenergan, if needed. So we do a concerted effort to try to decrease use of narcotic post-operatively. Thank you. Dr. Nguyen, good morning.
Ninh Nguyen from UCI, very nice study. How do you select which patient is going to undergo a toothpaste fundoplication versus gastropexy? Obviously, the fundopexy is not an anti-reflux procedure. And in my practice, if you have enough intra-abdominal esophageal esophagus, which is really the determining factor, then I would no doubt perform a fundoplication. The only reason I would ever just do a fundopexy is when you don't have enough intra-abdominal esophageal length, and you don't want to proceed with a callus, fundoplasty. So how do you select?
We perform all of our fundopexies after full esophageal mobilization. None of them was performed because we could not obtain. None of our patients required callus gastroplasty. As you know, the peptic ulcer and the stricture and the long segment Barrett's esophagus are the predictors of need for callus gastroplasty, which is more common on a patient that may have type 1 hernia versus a type 4s. Selection is as follows. We have completely changed our management. All the patients above age of 60 that they come to us with the type 3 and 4 hiatal hernia and dysphagia as a main complaint, they get a fundopexy. Young guys or female or male that come in with the main complaint of heartburn and regurgitation with a type 1 hiatal hernia, they get Toupet. Now, we published a study, we compared symptomatic outcome between Toupet and fundopexy, and we show no difference. But I think we should have subjective data on that, and we are working on bringing all of them back, do an esophagram, endoscopy, endoflip, and identify, because it is a possibility that fundopexy may have anti-reflux effect as well by the angulation that you can create. I've mentioned on that study that we published, 12% of our patients require dilation. When we brought them back to dilate them, you don't see any sign of esophagitis, but that's to be determined.
Great study, makes me happy. I just take stomach fat for cancer. This diclofenac gel to the shoulders, I'm finding really interesting. I've never even heard of that. Have you individually looked to see if does it work? I'd like to know more about it.
Yes, actually, Anthony presented that, is working on another one on that. Josh and Anthony, both of our medical students, are working on the effect of Voltaren on their shoulder pain. As you know, a lot of this shoulder pain we call referred pain. Nobody knows why. Nobody knows why it's more on the left and the right. But one thing that identified that if you combine that for exercises post-operatively, decrease the need for narcotics. That's thing that objectively we could identify. So we measure all the narcotics they get post-op, and it was less in a Voltaren group. But you can discuss that if the nurse comes and massages your shoulder, even with Vicks and Nivea, you may have an effect, right? So you have to compare that with something else. But definitely Voltaren helps. And we ask the patient after they leave, do you think Voltaren helped? And majority says yes. And then we ask 18 nurses, and 12 of them, they think that it improves the pain.
Where do you tell them to put it? Because most of the time, if you say shoulder, it's here, whereas most of that referred pain is here. Do you have a protocol?
Yes, we have a protocol. We goes all the way from shoulder to back of the neck and up to the elbow. It's a full massage, and it's done by the nurses, and is divided by our physical therapies associated with the exercises on the shoulder, the 5 abduction. Yes.
Rifat Latifi, Phoenix, Arizona. Outstanding presentation, great work. Have an issue with the definition of emergency surgery. If I'm not reading it wrong, it says the time from consultation to the operation is 42 to 79 hours. How do you define that as an emergency?
So we define emergent procedure, all the procedures that they came, port of entrance was our emergency room. So they were all the emergent procedure. Means I did not see them electively in the clinic, and I scheduled them as an urgent case, because we recommend procedure on this patient. Takes about 7 hours with those guys to call us for the consult. And then in our emergency room, I don't know how it's yours, if you walk in front of the emergency room, you go right for a CTPA. So 20% of our patients got a CTPA and all these unnecessary tests that they need. Everybody short of breath, CTPA. But that's how we define them.
Well, you know, because if I try to book emergently a case 42 hours from now in the operating room, they will not take it. So they would be really elective or semi-elective, perhaps urgent. So that's the issue is when we report these data, if I say that I do an emergency abdominal wall reconstruction, perhaps I'm diluting the real issue. So I was just wondering that.
No, I understand what you're saying. You say you do emergent procedure, means from here directly go to the operating room. I understand that. But for the purpose, sure. Our hospital, we have 265 beds in our hospital. Our OR availability is really good. It's never been an issue. The reason this patient that they came from the emergency room, they were not operated on there immediately because we like to decompress the stomach if it's possible. So we do endoscopy if there is no ischemia and perforation. We like to decompress because we think that the stomach, when it's distended and you operate on them, can pressurize the heart and lungs, as you know. When you want to grab the stomach is very distended and can cause perforation. So the reason to wait is not because we couldn't do it right away, because I think patients benefit if you wait and then operate on them. I hope I explained the best way that I could.
We have reported almost 500,000 patients with various issues on NIS database. And we call it same hospital admission operation. We don't call it an emergency because some of them take 2-3 hours, some of them take 3-4 days. So we call them an operation at the same time, that when emergently admitted for an operation. So that is it's a matter of semantic, I guess.
Sure. But all these patients that we call same-day surgery, they went home that day without staying overnight after the operation.
Thank you.
Thank you.
So thank you for all the fabulous presentations. Do we have any other questions? If not, then I would like to entice the audience to donate to the Western Surgical Foundation so we can actually increase the rewards and awards for our fabulous presenters over time. There's a QR code that you can use. You could go to the registration desk or you can go to the website. And otherwise, I'll see you all at the Legally Mine luncheon next door. Thank you.